Hello, I'm Dr. John Bray, and I am going to speak to you about a subject which I think is tremendously important. I think what we're going to speak about today is the commonest cause for chronic constipation. This is something that really isn't known about, so I have to basically do a sales job here. I think that when there are kinks in the rectum, these impede the passage of stool, and the patients feel tremendously symptomatic. Let's start right away with a patient. This is a 67-year-old woman who for the whole of her life has struggled with constipation every day. She really doesn't usually get a sensation of stool in the rectum. She just can't have bowel movements, and she would go for days or weeks without a bowel movement, getting tremendously bloated. But what I've done here is I've filled her rectum with a paste. The paste is made of barium, so when I take an x-ray such as I'm showing you now, we can see it as a white shadow. And I've thickened the barium paste with dehydrated mashed potato flakes to make it into the consistency of soft stool. So to all intents and purposes, I've filled her low rectum with pseudo feces, and it just feels like feces. And just to show you, all of the white collection is the paste. I put 10 ounces in. Down here is the anal canal, and the top of the anal canal is gaping open. This is a manifestation of a normal reflex, the recto-anal reflex. Just to make things easier for myself, I've smeared some paste on her skin in the bottom of the butt crack here and a little bit on the perineal body here. At this time, the patient told me that she had a sensation which she really is not used to, she's never felt before. And of course, that's a sensation of stool in the low rectum, the sensation that most of us get most every day. But she has never felt this before. And I ask her, at this point, I ask her to defecate, and she starts to poop. And the lower rectum is now much narrower, much emptier. There is this pseudo-feces filling the anal canal. Notice the low rectum has a rather irregular or shaggy wall. I call this traumatic proctitis, and I'll be talking about this a lot in series 2. The middle third of the rectum, which is this big white blob here, is still full of paste. And let's move on. Here are 2 later films as she's trying to evacuate more and more. The lower third of the rectum is almost empty. The middle third here still contains paste, and same again here. And notice at this point that there is a 360-degree angle, like a hairpin bend at this point. Let me just show you a diagram to explain what we're looking at. Her rectum is bent or folded like this, and there are 2 folds. I call this one at the front fold X, and this one back here fold Y. And these 2 folds actually convert her rectum into 3 potential compartments, compartments A, B, and C. And I'm going to speak about these quite a lot, so remember this nomenclature, it'll make everything easier. Just putting that diagram side by side with her. This back here is compartment C, here is compartment B, and this ragged material here is a little pseudo-feces mixed with a lot of real feces in compartment A. Now, confusingly, there is some barium up here in the small bowel. I have all my patients drink a cup of barium an hour before the test so that I can see the relationship between the small bowel and the rectum, but in this patient it is of no consequence. We don't need that. This is the final film. Note this is coned in a lot more closely, but you can see compartment B here is still full of my pseudo-feces mixed in with a lot of nuggets of real feces, and compartment compartment C here is potentially empty, and there's still a little bit left in the anal canal. And she couldn't evacuate any more than this. Just a diagram to show you these valves. The case I have just showed you, I chose because there is a large compartment B. It makes it easy to explain. But in truth, compartment B is usually much shorter, and often compartment B doesn't even appear until the patient strains to defecate. So the patient is straining here. This, I call it the hydraulic ram, is compressing the mid-rectum, and it's folding these two 360-degree bends. And when that happens, we create two flap valves. The back wall of the rectum here pushes against the very back wall and impedes passage, and then another flap valve occurs here. More than that, there's a third valve. Above fold X, imagine a large nugget of stool now wedged into this narrow area. It can't get around here, so it blocks it up, and this works like a ball in a ball valve. And this actually explains kind of an important symptom. These patients tend to live on large enemas, large volume enemas, and sometimes they get rather frightened because they push, say, a quart or 2 quarts of water into the rectum, and they sit on the toilet and it won't come out. And I have to confess, for years I used to think, for whatever reason, this symptom used to irritate me. I would think something like, you silly woman, you've put it all in there, just sit and poop it out. But actually what's happening is this ball valve problem. When they're filling, the ball falls away out of the narrowing and they can get this litre of water into the colon, but when they try and evacuate, the ball gets jammed back into the ball valve and causes the blockage. And the secret is not to panic, just to go and lie face down for a few minutes, and when they do that, the ball falls out of the valve and water once again can get past the ball and get around these folds into compartment C and get defecated. By the way, water doesn't hold up at these flap valves. It's mobile enough that it will get through, as will gas. Gas and water will go through. I call them shape shifters because they can accommodate to the narrow passage and get through it. Whereas the thick feces won't shift shape and it just jams up.